Good morning. I flew in this morning, and what great weather! Not having humidity coming from South Florida is great. My skin is already bouncing up, cheering. What a great talk to follow, because I think my talk is going to be a little different, taking a different approach, trying to be here, trying to discover with you, hopefully not speaking at you, even though I'm kind of on a stage. And trying to think through, the title is, I don't know if we can upload the slides and start my timer, otherwise we'll be here until dinner. Yeah. I have a clicker. Oh, I just go forward?
I don't know. Let me
No, I tried. Didn't work, yeah. And what a wonderful talk to follow. There we go. So what a wonderful talk to follow. Really a lot of great information. And one of the things I'm going to try to do, hopefully, is inspire you to try to think how to take all this and act on it. I love the idea of this is kind of a long pathway, that quote at the end from the previous talk. The one thing I will push is on the chamomile. I think we are a jasmine kind of conference, right? Okay, all right, good. Okay, good. Good, okay, good. Yeah, all right, thank you. I was working on it, trying to see how that's going to work, but no. Okay, jokes aside, the task I've been given is, so you've been diagnosed with HS, now what, okay? And I think I'll try to, what I try to do is sit down and think, okay, there's all the scientific slides, and I have a deck on HS, about 450 slides and counting, or just make a lot of these are kind of new slides that I'm trying to think together. From my experience of seeing this one, probably hundreds of patients. We actually looked at our data. We have, this is the entire university, not just me, but over the last 10 years, saw about 3,500 patients with HS, including admissions to hospital, and seeing all the way from 9-year-olds to 80-year-olds, all the way from very, very mild to the most severe, requiring surgery, admission to hospital, really devastating cases. And then trying to say, okay, how do I do this in about, we have 45 minutes, we can start the timer. I actually want to have more of a discussion, so I don't have a lot of slides, so don't worry. Thank you. And really try to think what kind of tips I can give you, okay? Not being a patient, not having to deal with this, but from my perspective. So this is my disclaimer. In addition, my other disclaimer, I should say, I didn't list it, and I'm realizing now, but I do work with a lot of industry partners, some of the tables you see out there and others, and it gives me a good perspective to know kind of what is being discussed, what is the horizon, where is this going, what can we do. In the title of this, my long spiel here, you can see that I also work with the Hidradenitis Suppurativa Foundation, the HS Foundation, which is a near and dear to my heart organization, and I have the privilege of serving on the board of directors, and that gives me an opportunity to interact with patients, with other stakeholders, to really try to advance what can we do for this problem right now that's devastating about 1% of the population, right? We hear these numbers. 1%, that's like 3 million people in the US. There's a 16-year-old girl now who's thinking about her graduation and doesn't know what kind of dress she can wear, right? Like, this is what it means to me, yeah? And trying to find solutions for that, it's an enormous task. Okay. So this is kind of the outline. I was sitting down thinking, okay, what questions can we answer based also on the tasks I've been given by the organizers? But I'm going to start what I call why we are here, but also what's HS, briefly, who takes care of HS, how is HS treated, and what resources are available, and hopefully help you kind of build this, this power pyramid to empower you to take care of this problem. So I'm going to take a beat here and have you look through these questions and think, do you have answers for this? Do you know? So what's HS? Who actually takes care of this? And once you get to that person or persons, how is it treated? And then what resources you have? Are you aware of? What resources are you using to handle this problem for yourself? Okay. So hopefully we can think together about all these, okay? So we'll start with why are we here? And why am I here to talk to you? And I think one of the major issues that I see daily, not just with HS, just daily taking care of patients in the United States in 2025 is the issue of health literacy. And this is a formal quote I found that says that health literacy is the degree to which individuals, so that's you and I, okay? Recently had to guide my wife on a medical question. I was like, I'm not sure how we do this, right? And so it's individuals, you and I, have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. So there's a lot to unpack here, right? So it's the individuals, it's us, you and I, trying to find, okay, first of all, where do I go? Who do I talk to, right? Then understand, right? We just had like an amazing talk, but that was a lot of information. So how do I do this, right? And then act on that information. There was a talk earlier about the barriers with insurance. So you may get the best recommendation from the best person and then you're stuck. So how do you use that information or services? And all that is meant to really get you to health, right? To inform you about how to make those decisions. And most of the time it's for you, but a lot of times towards the end of life or in other circumstances, it's for others, right? And I think SpongeBob summarizes this beautifully, right? So knowledge is power. And this is kind of the foundation to what I want us to talk about is to understand that the more you know, the more empowered you are to take care of yourself. But at the end of the day, it's the individual in the center. It's you, okay? And what you're going to put into it is how much you're going to get out of it. And it's true also in this particular case. Looking up at other statistics, if we take 10 people in the United States, right? How many of them are struggling with health literacy issues? Okay? So the slide kind of tells it, but the statistics suggest that 9 out of 10 people in the US, that's a staggering number, kind of really in one way, shape, or form having issues. And I just told you myself, right? Being trained by the system, practicing, working the system, still, there's sometimes a question like, I'm not sure who's doing this, right? Lucky for me, I belong to a bunch of chat groups with other doctors, so I just like, who takes care of this? And then somebody says, oh, there's that, right? But the average Joe American doesn't have that kind of access a lot of times. And so this statistics is not meant to scare you, just to let you know you're not alone. We're all kind of struggling with the system, trying to understand it. I think in HS, what's unique is that of all the skin diseases that I treat, by far the most multidisciplinary, can be treated by so many different doctors and so much other information that's out there that can be almost paralyzing. And that is something, hopefully you find comfort in the sense that you're not alone. And you're here, so you probably understood that already. Here I am preaching to the choir. But why is it important to develop that health literacy? And that's the one data information I'll have here on this, is that there is a link and association, okay? I want to spend a minute talking about the word association because it was mentioned in the previous talk. So association is very different than causation in science, at least, okay? Right? So the fact that one thing happens at the same time as another doesn't mean that one of them is causing the other, okay? Right? So if you, I don't have a good example off the top of my head, but let's say if you wore a blue shirt and you got fired from your job, it doesn't mean that every time you wear blue shirts, you're going to get fired, okay? It happened on that same time. It could be that you have a boss that's colorblind and thought that you wore a shirt that has the middle finger on it every day of your job, and that's why you got fired. I don't know, but you understand the concept. But there is association for people who have poor health literacy, people who can't really understand the information the doctor is giving, can't really access the information that they need, with all these really poor outcomes that a lot of them would make a lot of sense for HS. For example, people with poor health literacy tend to use emergency care more frequently, and that's not a good thing. We don't want to treat it at the end of the process where we're stuck with pain 15 out of 10, drainage from all the tunnels, barely walking. That's not a good idea. We don't want to get there. And having more hospitalization. It costs more, both for the individual but from a system point of view. Just in general, poor health status, poor ability to interpret labels and health messages, decreased use of preventative services. My gosh, we really need to leverage every preventative service we have. And of course, the worst of them all, higher mortality. So the more you know can actually save your lives. And I want to take a step backwards here. Things are pretty good, right? 100, 200 years ago, people lived probably half as long as we do, so we are in a good situation. So we don't need to be so discouraged, but there's, with knowledge comes complexity, and we're hoping to demystify it. So that was kind of my piece on why we're here, why are we here together? We're here to together try to figure out what we need to know kind of in our back pocket as we go and handle now the healthcare system. So let's talk about what's HS, okay? Like I said, I have a 450 slide deck on this. In that backpack, I have a grant I'm reviewing, trying to figure this out. It's still a question, right? And I'll get to, because the question is, what's HS? So first of all, this is how it's spelled. It took me about 3 years to spell it right. It's pronounced Hidradenitis Suppurativa, but I heard people say Hidradenitis Suppurativa. You're not wrong, okay? That's why we call it HS, because it's so much easier, okay? It probably cuts down a full minute of every visit that I see patients if I had to say Hidradenitis Suppurativa each time. If you see in the internet or if you read scientific literature in Europe, a lot of times the term is used acne inversa, okay? It relates to the idea that some of this, and I'll show you in a minute, could relate to acne, but inverse distribution in dermatology means distribution in skin folds, right? The classic example is probably we heard about psoriasis here, kind of mentioned. So psoriasis is on extensor surfaces, right? But you can get inverse psoriasis, meaning psoriasis in the skin fold, and HS happens in skin folds. So the idea was, okay, acne inversa, and this was years ago before the disease was described as eloquently as we can describe it now with all the beautiful tools that we have scientifically speaking, okay? That's the name. I think it's important to know. Okay, how do we diagnose it? Okay. This is a question that actually dermatologists, okay, that have far advanced, I see Dave Lou nodding because he knows where I'm going, right? I ask this to dermatologists and they're like, wait, I don't have diagnostic criteria. Wait, how do I do this? What? Hey, wait a minute. I just know it because I see it and I know it. And it's true. It's probably one of the easiest diagnoses dermatologists have to make. 95% of the time, right? It's just we don't think about it. But the reason, but there are criteria, and it's good to know because most of the doctors that see HS are not dermatologists, okay? I'll say it again. Most of the doctors that see HS may not even recognize it as HS, right? And this is, again, thinking about your health literacy. So you as a patient coming in, you should know, and you can prove. So I'm going to give you now the tool to prove it, okay? And I like to call it the 3 T's, okay? And this is what it is, okay? The typical lesion, in the typical location, and recurrence, I say it's the typical story, right? So this lesion, I'll show you the terms, but whatever it is, boil that you get, okay, is in a typical location. So we talked about skin folds. And then there's the recurrence story. It keeps happening. Okay, so there's a typical story. Oh, it started when I was 18. I got my first bump when I was 16, when I was 45, whatever it is. But then it keeps happening. It doesn't go away, all right? So there's that story. So let's break it down. But at the nexus of all this, if you have all 3, you can pretty comfortably say that you have HS. And actually, this has been studied, right? So if you give 100 patients this question, did you have a boil and a skin fold over the last 6 months? A couple of those kind of alluding to the recurrence. There's various ways to ask this question, but if you ask 100 patients, over 90% of the time, they will be able to discriminate and accurately diagnose themselves with HS. That's not easy in medicine in general, let alone in dermatology, right? How many times is like, oh, is this bump a melanoma, right? There's no question for that for melanoma. It doesn't exist, right? That's why HS is so easy to diagnose. It's just most of the people that see it don't know they're looking at it, okay? And now you have it. You can do this, okay? So let's break it down a little more. So what are the main lesions in HS? And I didn't include pictures here on purpose, but I think you probably have seen many pictures so you understand what I'm talking about. But you have nodules, abscesses, and tunnels. So nodules are just a lump that's under the skin, but you can definitely feel it. It's more than a centimeter big. It can be red and tender. Abscess is something similar, but it can drain pus out. It's a little more fluctuant. Anybody here ever did water balloon fights? Okay, all right. So imagine that water balloon and you kind of, oh, you press it, there's a little give to it. It's a little, you can feel there's fluid into it, right? That's an abscess. It's under the skin, okay? Abscess is probably the #1 problem we have with diagnosis of HS. Why? Because abscesses can be infectious and random, and they are very prevalent. And so when you go to the emergency room, they see an abscess, they say, oh, it's an infection. But HS is not really an infection, right? And so you go to the emergency room and they say, oh, it's an abscess. So if you tell the doctor, I know it's an abscess, but I don't think it's infection because I get those every month. And then the doctor will stop and think, right? And then maybe they'll Google something and they'll say, oh, okay, maybe you do have something different, okay? That's why this information is useful. Because in the United States in 2025, most patients don't see one doctor continuously. So this visit with the abscess, 1 month happens in the emergency room, 3 months later in the urgent care setting, 3 months later in the primary care office, 3 months later in the gynecologist's office. Between these 4 providers, nobody can piece it together, only you. That's health literacy. That's understanding what's going on. That's the empowerment that I hope you get out of this, okay? So tell them, look, this abscess has been happening again and again. If I had infection for the last year like this with Staph aureus, I would be dead, okay? It doesn't make sense. It doesn't add up. So I think I have something more chronic, more inflammatory. And what you get out of this is suppuration, and I put this just because it's a word that's going to be there, but it's a fancy word for a lot of pus. Okay, so fluid exudate, sometimes it's called, coming out. Scarring at the end of this, which is what we're trying to hoping to prevent, and pain, okay, which is a very complex problem in HS, just starting to understand it. There's different types of pain. So that's the key lesion. Know your lesions, know the location, skin folds. It turns out that we have certain distribution of different glands on our skin, and one of them, called apocrine glands, are in the skin folds. And in the beginning, it was doctors that, many of them may have been naturopathic doctors, but for hundreds of years looked at patients with HS and saw this pattern and said, it's got to be the apocrine glands, because that's the only thing that I can really see. And if you see on this picture, yeah, you can see in orange, it's the apocrine glands. I don't think I have a pointer here, but you can see armpits, groin, right? Breast, but also node kind of behind the ears, right? And that's another common place for HS that I see quite a bit. So it makes sense. Turns out the apocrine gland is, to our understanding in 2025, doesn't really relate to it, but maybe we'll find out. But it is usually in skin. When we see that association, it means something. But that's the location. So the locations are skin folds or areas of, that have a lot of apocrine glands. And there's definitely what we call atypical areas, right? So once you start getting HS, you can get it in other areas. So you can get it, on the side of your abdomen, right? In the skin folds, anywhere you get a skin fold, you can get that. So once you start getting it in those typical locations, but like I said, over 90% of the time, this trifecta can really diagnose. So you're pretty good with that. And of course, chronicity, we talked about that. Okay, so now you have kind of what's HS, how we diagnose it. What is happening under the skin, okay? All right, so when patients ask me, why do I have HS? I say, I don't know. But there's a few things that have been associated, and that's what we're going to try to go after, right? We talked about the word association. So what I'm going to show you, this is actually an old picture. In 2018, in HS world is ancient history. That's how much advancement we had. But I just think the picture is so good here. So I've added a few things, if you don't mind, okay? But to orient you, where it says the number 1, this is sunshine, this is the outside of the body, this is cool and fun. Then all this thing is the skin, and then where it says, the citation down 2018, that's the inside of the body, okay? This is a magnified model of the skin. And what we see is a hair shaft, the actual hair itself, coming into this dimple in the skin, right? That kind of like U-shape, that's where the hair lives, the hair follicle. And turns out that it seems like HS is starting there. And it starts with this occlusion. So again, I don't have the pointer here, but you can see where the hair comes out of the skin, there's some stuff crowding it, okay? All right. If this happened on any given day, all of you had it here. I don't know if you're a patient, doctor, you all had it. It's called acne. You all had a zit, okay? And for some reason in HS, these pimples happen, and strange locations. Acne is usually on the face, chest, back, not in the armpits, right? And for some reason, that's a pimple that decides to burst on the inside, okay? But it starts with this dilatation. So I'm going to point your attention, because I think this is important. What is HS? Well, there was talk before about some exogenous factors, things on the outside. I find that friction is by far number one, but when it comes to outside, smoking, in the US, actually, not a lot of people with HS are smokers. It's more in Europe we see that. And I think in the US, it's actually less than 50%. So, but smoking definitely has been strongly associated with HS. Obesity, for some reasons, some of it had to do with the friction, some of this just with the inflammatory state. And hormones, that you see, that's my addition, because, and I say, wait, hormones come from the inside. Why I say exogenous? Well, that's why I said the talk before was great, because some of the foods that we eat, the environment we're in general, is definitely pushing our hormone balance out of whack, so to speak, and pushing specific hormones. The two main categories are the sex hormones, the androgens, and the other one are the metabolic hormones like insulin and insulin growth factors and all these that play a role. But also on the inside, we have some genetic susceptibility and hormones as well. So when people say genetic susceptibility in HS, again in 2025, it's not a one gene thing. If you remember in biology, there was a study with that, what's his name? It's like a monk that did all these hybrids with flowers, and he was able to take one, I think Mendel. I was a Mendelian, but it's Mendel. He took one flower with one color and was able to just smush them together. You can actually probably do it yourself if you wanted to, but because that's a single gene. But in HS, there are many, many, many genes that are probably involved. And so I think it's reassuring you can't blame one parent. Because, oh, mom gave it to me. There's multiple genes. And again, in 2025, we don't know exactly which genes. There's some clustering. There's really, really new data coming out. Now we've got a list of about 8 genes that maybe are associated, but it's not 100% kind of thing, okay? It's not a single gene in a single person, and it's not that 8 genes have to be dysregulated, kind of out of balance to cause one. So, but there is some genetic disposition because we know it sometimes runs in families, right? So some of you have seen that, right? Yeah. And what is kind of sad, and that's again talking about empowering you, is that I've had patients that tell me, oh yeah, it's just my boils. My mom has it, my grandma has it. It just runs the family. We don't need to treat it. Like, we can help you. No, you don't have to live with this, right? But it's just been going on. So that's kind of the genetic factor and understanding, oh yeah, it runs in the family, but it doesn't mean it's a good thing. Okay? So we can take care of this. We can help each other. And you can educate your doctors about that as well. Here's a pet peeve of mine in the patient interaction, right? So a lot of my trainees will ask, do you have a family history of HS? Okay. First of all, family history is like, sounds a little strange. It sounds very medical. Like, do you guys talk about it in the family? I don't know about you around dinner. I don't sit around for dinner and say, hey, Mom, I got a thing right down there. And I would never say that, right? So when it is okay to tell your doctor, I don't know. We don't really talk about it. Some people really know, and that's great. But if not, it's okay to say, I don't know. It doesn't mean, the answer is not no. The answer is I don't know, okay? And that's okay. That's fair. You don't have to know everything. It's fine. I don't know everything about the healthcare of my parents. It's perfectly normal. Okay, so we have this dilatation, and I just told you this would be a regular acne zit, a pimple, right? But for some reason, because we have some exogenous factors, because we have some internal factors, this goes totally the wrong way. It bursts into the inside of the skin, and then what you get is robust inflammatory soup, okay? All this alphabet soup and all these terms that you need, cytokines, chemokines, all the kinds and all this thing, some of it has been elucidated, a lot of it is not. It's just a big soup of inflammation. But nobody knows which one of these letters comes first. Nobody can say, oh, it's just one of these letters, right? It's a complex process. And again, in 2025, most people look at this problem, but speaking of root cause, they're not looking at the earlier lesion where we try to really understand why this is starting into that pathway. But once this cat is out of the bag, so to speak, right? I think in this image it's pretty clear it's out of the bag. Then inflammation is rampant, right? And your skin is going to develop this pus and pain and redness, and it's going to be a problem. And as the disease advances, it really starts to connect. So now in this picture, you're seeing multiple hair follicles kind of burrowing. The disease burrows under the skin and does this kind of, I'll step out of the picture. You do not want my head in that picture. So there's connection. Those are the tunnels, right? So I want to add a few things here. One, we talked about inflammation. We talked about friction, obesity, hormones. We talked about maybe being genetically susceptible. Here, what also we didn't mention is the microbiome. So microbiome is the normal composition of bacteria that we have on our skin. We just heard in our gut. Anybody, oh my God, okay. Anybody is freaking out to learn that most of you is not you. Most of you is bacteria. Okay, everybody knew that? Fungi, yeast, right? Viruses, yeah, it's everywhere, okay? And most of the time, it's good, okay? Turns out in HS, that balance, that delicate balance that we have is imbalanced, okay? And all the bacteria that were supposed to be good are less, and then we have these bacteria that are not supposed to be there, all of a sudden becoming a majority and kind of dictating the rules, leading to all this problem. And even in the tunnel, you find this thing called biofilm, which is a fancy word for a neighborhood of bacteria. So you take a couple of bacteria, put them together, they develop this neighborhood that protects itself, okay? So if you give antibiotics, right, the disease gets better, but the moment you stop, because all the bacteria run into their neighborhood and hide, they don't cause a problem. And then they wait and say, okay. They actually have a system to recognize when it's done, the antibiotics is gone, they come out. And again, don't cause an infection, but they're just enough maybe to piss off your immune system so much that it spewts out all this alphabet soup, okay? So, what did we see on What's HS? We reviewed all these factors that are associated, not causative, associated. And we see that there's, if you let it go, you get what we call tissue destruction or scarring, okay? This is kind of the end result of this. And so this is a question I get a lot. Why do I have HS? I don't know. Everything I just showed you is an association. Most people, I think, ask me is, why me? Right? It's a profound question. It's so hard to deal with in clinic. And I don't know. Doctors can tell you what and how. It's very difficult to tell why. There's a lot of investigation, but in most of medicine, it's very hard to find that pinpoint arrow that will solve this problem, okay? It's not a silver bullet kind of problem. And we found there's associations, but we are very, very careful at saying this is causing it. And the reason we're careful is not because we're shying away or because we don't know all this beautiful information, for example, you saw in the previous talk, is because, yeah, I'm aware of the association of these yeast antibodies. I actually check all my patients for them. But you know what? Only about 10% in my experience come back positive, and when they change that, they have to cut off, pizza and bagel and beer. Sucks for life, right? No beer, no pizza, I mean, come on. But they have to do this. Only some of them get better, okay? And when I give them, by the same token, I can give them one of the biologics, and good number get better, but it's not a silver bullet. And some people get surgery, and they get better, but it's not a silver bullet. So I take all the information together, and as of today, what I know in 2025 is that I need to pour as much treatment as I can to halt the disease, to not get to that tissue destruction, right? But I say doctors know what and know how. Why is maybe a question for God. It's more of a spiritual question that I don't know I can answer today, okay? So it's a limitation that we have, and it's difficult, but I think you have to kind of get past it and say, okay, here we are, this is what we know, let's act with that, okay? And I don't want you to interpret the fact that doctors are honest in telling you, I don't know, with I don't know what to do, because they do, most of them. Okay, so who takes care of HS? All right, throw names. Who takes care of HS? What kind of professional, what comes to mind? Who takes care of it? Dermatologist. All right. Thank you, everyone. Okay, good. All right. Yeah. So I wrote here in the center, dermatologist and you, okay? It is a partnership 150% of the time, and dermatologists are, I hope, can be the quarterback of all this. And I think there was a question here earlier about, approval to see a doctor in a certain location. I get people travel from all over the country to come to see me, okay? And I send them back to the dermatologist and I say, your dermatologist is well trained, I'll give you some pointers, and I can quarterback here, all the way here from Miami, and you're fine in Alabama and Atlanta, wherever you are, okay? Because dermatologists are very good. They know what to do. Sometimes it's more of a setup of the practice and other limitations. But in terms of knowledge, a board-certified dermatologist can and should be the quarterback of this. You don't have to go all over the world trying to find that one expert. HS is not an HS expert disease. It's a dermatological disease, and dermatologists across the board, all around Europe for sure, in the US and Canada, in Japan, those are kind of the places I can think of. Australia, we have excellent dermatologists. They all should be able to take care of this, okay? So don't feel like you have to. You should go if you want to seek the expert to see them once, great. Have them the quarterback. Because then comes all of this around, okay? I don't think there's a single disease in dermatology, and probably a few in healthcare in general, where we have such a wide team. And maybe some of you can come up and say, oh, there's one more. Heck, on the flight today, I realized I forgot wound care. I just added this. I'm like, me? I was like, how did I do this, right? It's like my favorite. I can't believe this because it's so complex. And speaking again to what can you do about this is to recognize, oh my God, do I need to see all these specialists? No, you don't. But in one part in your path, you may see a different specialist. So I want all of you to kind of look at this and think, is there someone outside of dermatology that you saw, right? Did you see at least like a gastroenterologist or, well, primary care pediatrician probably all, but did you see an emergency medicine doctor, hospitalist, which is the doctor that's inside the hospital in the US model at least. There's so many doctors, right? And professionals that help you with the management of this. And then you may think now that you know all this and say, oh my God, I totally should see a nutritionist, right? That's the power I want you to have. To say, okay, I know I have a dermatologist, and maybe they're not so good talking about nutrition, and I'll acknowledge we don't get education on that in medical school. So that's a great time to maybe seek a naturopathic doctor in the licensed state, right? Or other nutritionists. Naturopathic doctor get excellent education in that most MDs and DOs do not. And so try to build that team around of specialists that are for you, okay? But definitely the dermatologist and you are in the center, and then quarterbacking all the other specialists, trying to balance all this. This can be very overwhelming. So it doesn't all have to happen tomorrow, okay? And we can go some of these terms if they're, I'm trying to leave some time for questions at the end. Okay, how do we treat HS? Okay, I'm not gonna give you a degree in medicine right now. That's not the point. I'm going to give you a picture and understanding of what's happening so you can navigate and educate the right healthcare provider you encounter so we can do this. So, okay, I'll speak broadly, okay? I'm listing here two main axes that we're trying to treat. Two major key elements in the disease. One is inflammation, and you can see it in your skin, but also you heard before, can come from the gut, affect your skin. There was mentioned, I think, alopecia areata and vitiligo and all these other associations. There is a broad inflammatory process also in the gut, the association with joint disease, with gut disease, right? All this inflammatory process that is happening on one hand. And then there's the scarring, or we call tissue destruction, that is another part. And broadly speaking, one manages inflammatory pathway with medication, and maybe we heard with good sleep, and everything was greatly put, so I'm not going to get into that too much. And then scarring usually with a procedure, and hopefully prevent, right, the scarring. And if you have these scarring or tissue destruction kind of processes like the tunnels in HS, then you want to treat them with a procedure, because in 2025 today, the medications we have do not uniformly treat tunnels. They can help. They definitely reduce their size, make them not be so inflamed, and maybe heal the early ones, but they're not a silver bullet, so we have to combine this. The third axis here is an axis that's often forgotten, and that's the life impact that HS has on the patient. And again, in 2025 in the US, in the healthcare environment that we work, dermatologist and you, the dermatologist will not have time to get into that. Definitely not in the first visit. But you want to keep it in the back of your mind. You want to remember, you're part of that team. You work with a dermatologist. And you can say, you know, it's really impacting my work. Well, we can put out a fire on visit 1. Maybe we can do some, write a letter to your employer. But in the back of your mind, we want to revisit it and see how it's impacting your work and what can we do. And that may be in the 3rd or 4th visit, okay? Or maybe we just need to involve social work. I'm just giving you one example. But these are the life impacting that in the professional jargon, you may see patient-related outcomes, PROs as they were. It's really jargon. This is really what I say when people ask me about quality of your life. I say, how crappy is your life because of this, right? What does it do to your life? So I don't want to forget that, okay? These are, I put here, these are the North American guidelines. So these are the guidelines that doctors look at, okay? You don't have to know all of this, and it's available for free. I'll show you where. But it's just conceptually so you understand. And these will be updated soon because they're getting old. For example, these two medications were not available, now are available, FDA approved. But you can see conceptually that it goes based on the severity on the top. And then there's medical treatments, as I mentioned, procedural treatments, and then also treatment with the flare, okay? And here's where you can help the doctor, okay? The word flare in HS is the most misused term I hear, because people come in and saying, my HS is flaring. Is it really flaring, or are you just not controlling it at all, right? Because if you have a flare once a month, around that time of month, that's not a flare. Your disease is not controlled. Your period is triggering it. Let's address that issue, okay? But if overall, you're doing great, you're going to work every day, and then just 3 weeks ago, you got this unbelievable flare, like a huge boil in your armpit, that is a flare. That's something we need to address, okay? So, but you can guide your doctor about this, because when you say flare, they're not sure what you're saying. They don't even know to think about this question. You can say, Doc, I don't think I'm controlling my disease well, or I can say, this is a flare. This is an outlier. This was not here before, and I think I'll probably get over it, but I'm in a flare right now. So if you use that term accurately, your doctor can actually give you good treatments, because if your disease is not controlled, maybe we need to switch a medication, add a medication, do something, versus a flare, we can just support you to go through this, and we don't need to change anything, okay? Big difference, okay? So along these axes we treat, and there are medications and certain procedures we can do, and I know you had talks about also surgery for HS, so I'll leave that for the Q&A. This is newer guidelines coming from Europe, okay? And the reason, again, I'm including this is because I want you to see that they think also along the same lines, but they call it active inflammatory on the top, and then based on the severity, they can give you certain treatments. And then on the top, on the bottom here, again, they're not forgetting that third axis, right? The life impact, so all this adjunct therapy. And the treatment is what you probably heard at this point a lot. So anti-inflammatories in the form of antibiotics that are used, and the biologic treatment and others. And then there's some procedures as well, and you can see that, okay? But they also include a whole new set of guidelines that are different for the non-inflammatory lesions, and that is mostly procedural, okay? So, big asterisk, this is the European guidelines, so don't go and show this to your insurance company and say, oh, this is on the guidelines, okay? Not gonna work, but this is the newest one, okay? And hopefully by the end of the year, God willing, and doctors agreeing among each other, we're gonna also have guidelines for the North America, okay? Okay, so that was kind of what is HS, how it's treated, who's treating it. The last piece is the resources that we have for people with HS, and this is where I'm not the teacher. You guys can probably teach me much more because I learn all this stuff from my patients. But I'll try to give you kind of a conceptual understanding. So the first thing, the best resource you have is you, okay? So we talked about it ad nauseum, but that's a theme that keeps coming. You may think that you're a little pawn, but you are the queen and kings of your disease because you know your skin best. It doesn't matter what anybody's going to tell you, okay? So at the core of this resource, you are the main resource, and you need to build the support system now to support you around you. And you know who that is, but it can be 1, 2, 3 family member, friends, significant other, I don't know, your Starbucks barista, whoever it is that you talk to, that you feel confident in sharing, and they bounce off ideas with you, but this is your support system network that you need. And then that can expand to include maybe in that network also your doctor and some other folks. But there are some organizations that are available. We are here in one amazing organization. There is other patient support organizations that exist. I include some links. Maybe there are others. Those are the big ones that I interact with. But there's other things you can do, and I'm so happy I came after this talk because you need to take care of your fitness. So who is your fitness part of your network? Who is your diet part of your network? Who is the human resources person that helps you to negotiate your job with a disease that, when moderate to severe, and even when mild, can really impact the way you work, right? So all this, and I include here a podcast because what's your favorite podcast for healthcare, right? Or for sleep? Right? That's a good one, okay? You can listen to my podcast. We'll put you to sleep in 2 seconds, okay? So whatever it is, but this is the network. Don't limit yourself to think that your network is just the people. It's also organizations, tools, people that help you address all the issues that impact you, and you start from yourself, the close friends, and then you build on top of that, okay? I'm going to talk about this resource because it's near and dear to my heart. So briefly, the HS Foundation. This is our website. And if you click on the resources, boom, you open a treasure trove of look at all this, okay? So for patients, for clinicians, for investigators, by far you're going to use the one on the left, and you can find a specialist in your state. You can read about biologics. You can read about research summaries that come through quickly. We have like all these little minions that Dr. Dave Louis is running around saying, come on, this study was published. Let's put something, but it's in plain language that humans can read. I got to tell you, sometimes I read it. It's just faster to understand instead of reading the entire complex science. Patient guides, educational videos. There's a pamphlet. You can print that, tell your dermatologist, hey, you should have this in your practice, right? Because they don't know. HS patient card that you can carry on yourself, other organization, and not spoken a lot about clinical trials. I'm going to leave it to Q&A. Please ask me about clinical trials because I think it's one of the things that we really underutilize. All I'm going to say about the middle column is show this to your doctors, okay? There is a lot of information that they can use for themselves to educate themselves about the disease, okay? So I'll stop here. I want to thank you. This is, seriously, I do have a podcast, so you can listen to that. We have a couple episodes on HS and probably have some more in the future. And I think we have plenty of time now for questions, so thank you. Okay. Yes, I'll repeat the question if you need. Yes.
Okay. So earlier in the talk you mentioned about like the microbiome and like on our skin and in our gut and how that affects the HS and even the severity of the biofilm. But my question is like there's so many of us who, especially early on, like I'm 40, I had HS since I was 13, so like so much use of antibiotics, which wouldn't that then make that worse? Like couldn't there be this like point
yes.
where the use of it exacerbates?
Yeah, so the question is about use of antibiotics and antimicrobial in general in HS, given the relationship to microbiome and the need to maintain a normal microbiome. I agree with you 100%.
Right, because it causes dysbiosis.
Right. So there's studies showing that just taking a short amount of antibiotic can wipe the entire microbiome of your gut, right? And then you have to recreate it. It's true. In medicine, as doctors, we sit in front of a human being. We don't look at the averages. We look in front of a human being and ask, what is the best we can do under the circumstances? And for many, many years, before we had these anti-inflammatory medications, the only thing that can relieve the pain, that maybe halted the disease to an extent, was an antibiotic. I hate writing them, but I hate even worse is patients in pain. Now, what do we know about this, right? So I think that we are very early in the beginning. So to put this in context, until about 10 years ago, all we knew about bacteria is we put a bacteria that we knew existed. So out of the trillions of bacteria, we picked one, Staph aureus, for example. We put it in a dish and saw if there was culture, right? And that was what we knew. Now we identify them completely genetically, okay? And that opened a whole treasure trove of, or Pandora box, if you will, of all this information. The question is what we do with this. So you heard, for example, about stool testing, gut testing, right? There's a caveat there, okay? Because what you get is an explosion of data, but we don't know what to do with that data. And there's a lot of danger in that. What do I mean? If you see, for example, that food X maybe caused, let me rephrase. You see increase in some factor in the gut testing. And you say, oh, when I eat this food, that may exacerbate, so I'm going to eliminate that food. A, it could be wrong, and I'll give you an example in a minute. And B, maybe you get now a deficiency. nutritional deficiency. So as physicians, we are taught to be very careful on what we clearly recommend and try to have it with data. For example, there was one of the earlier studies, just so you understand, to do these studies, you need mega computer. These are mathematicians are doing these studies, not even, they have to collaborate with doctors, biologists, but it's really a math problem because you have so many different bacteria, time points, the multiplication, and then 1,000 patients. You get trillions of data points. You need supercomputer to handle that, right? And so there was one of the earlier studies was about insulin resistance. And they took patients and studied their gut, and then they had journals of food, right? So maybe you know the study. And they showed like, okay, when you eat ice cream, what happens to your insulin? And when you eat broccoli, what happens to your insulin? And for a lot of patients, eating ice cream was not good, causing an insulin spike, right? But some patients didn't really spike with that. They actually spiked with broccoli. Uh-oh. What do we do with that? Do we say don't eat broccoli? I did not say eat your broccoli, okay? But it's just complex. So right now it's glorious that we have ability to now describe what we see. Now the challenge is for scientists to put this together into actionable recommendations. So avoid the antibiotics, to your question. Avoid what you can, but you don't have to suffer. Right. In fact, I just want to tell you that, I don't think you're with me, but this Friday, I was sitting with an HS patient, and I suggested that she go on a biologic, and she wanted to take antibiotics, and I had to convince her. She still wanted to take antibiotics because she was very afraid of the biologic, but I had to convince her. So you do what you can.
What a recommendation if a patient is on antibiotics and needs them, that's a great option for them, taking like probiotics along. Like, do you feel like that does long-term?
I think that probiotics can be helpful. I think you saw briefly that we can, with food, with good nutrition, you can really, and that's what the previous talk was talking about, kind of keeping yourself healthy, helping your body to withstand the treatment, not just the disease. So you can do that with food or with a probiotic. I'm a proponent of food. Good. So I think having food that can support a healthy gut microbiome can help you sustain the storm of an antibiotic that you have to take.
I think a lot of non-dermatologist practitioners, specifically with their HS patients, go so hard with the antibiotics, like 2-3 years consistently.
Yeah, I hate to do that. I think I have people that work with me here and can attest. I hate that. I try to take them off of that.
And the biologics would be a better option for reducing inflammation at that point.
For inflammation, yes, but antibiotics have their use. You know, some patients come in, they can't walk. I put them on ertapenem, it's pretty strong, yeah, but they can't walk. Yes.
I'm interested in clinical trials, but I work full time, so I didn't know like if there's options for people who like
Great.
Travel or things like that.
Thank you. Yes. So first of all, clinical trials are a great. At least now we are at the renaissance of HS. There are a ton of clinical trials, so much so that now they're having actually difficulty recruiting. Right? When adalimumab came out, right, they had no problem recruiting. Even for secukinumab, now it's challenging, right? Because there's options for treatments, and also there's so many studies. So it's definitely something you should always consider in the toolkit. In fact, I don't think the European guidelines are good enough because they don't mention that. And I think if you go to see a cancer patient, oncologists always have clinical trials. And I think in HS it should be like that. I do a lot of clinical trials. Patients, 95% of the time, super happy with the outcomes, very happy to be on it. You're like a VIP, and there's a lot more flexibility in scheduling compared to your average dermatologist, okay? So to start with that, for sure. You will need to be seen, okay? So right now in HS, in wound care, we do have some studies that are in the house, in the home, and that kind of flipped model exists. It's not yet in HS. The main reason is because the main assessment we have are not so good, and we have to count lesion, and it's already difficult and inconsistent enough to do in person, let alone remotely. So, but I will say that certain studies in the beginning are more intense. Maybe you have to come every 2 weeks in the first 16 weeks, the first 4 months. But after that, it's maybe once a month, once every 2 months. It's not so terrible. Most companies don't specifically give you reimbursement on travel, but all of them will give you a stipend. So every visit you come, you get an X amount of money. It's not going to make you rich, but it may pay for that Uber. And then, again, like we talked about, who's your human resources part of your network, right? So maybe your mirror. So recognize that maybe a letter to your employer. And I'm very big on saying, my patient has a skin disease. has a medical condition. I don't give them details. It's none of their business, and that's one thing you need to know. It's none of their business. They don't need to know about it. That requires them to come see me, and I'll list that if I need to. I'll list like in the next 4 months. It's just for the next 4 months. It's not all the time, and all that. But it's so I think it's not very different than regular care. And if you're going to take care of yourself, a clinical trial is a great way because you spend time with experts who know the disease. You're being monitored. You're going to learn so much. They give you tablets. I don't know if you've been in a trial, but they give you tablets that follow every outcome. Like your pain, you learn so much about yourself. It's almost like a self-reflection exercise. So I think all of our patients, we had, as you know, some of these agents went on the market when the trial ends. After 4 years, they have to get off. They have to go to see a doctor. They're crying. Like, what do you mean? I have to make an appointment? I have to talk to the insurance company? All that is obviated. And so it's a very positive experience. And your clinical trial should be able to work something for you. Yeah. Yes?
So to piggyback off of her question, if you're taking something short-term, like medicine, just for during the flares, maybe like a 7-day thing, and you don't take it for months later, do you still recommend a probiotic?
So the question here is if you take antibiotic for a flare or short term, do I still recommend a probiotic? Yeah, I don't think there's harm in that. A lot of time we do a risk-benefit analysis all the time, so there's no harm in taking it. I don't know if it's going to help 100% of the time, but it's not going to harm you. But the focus here, again, I'm going to flip it back, and I'm not going to let go. If you eat well and you strengthen your gut microbiome, you have enough of the good bacteria, then even a nuclear bomb that explodes like antibiotic in your gut, your microbiome will bounce back. Okay? Yeah.
I want to actually piggyback again, sorry, off the clinical trial question. My question is like, if people don't have insurance, can they join clinical trials, or is that
Yes.
a really good option for people without insurance?
So the question is, if you don't have insurance, can you join a clinical trial? Yes. Is it a good option for people without insurance? Not exactly, okay? It's not to replace your healthcare overall. We just talked about the whole network, okay? And clinical trials do not cover the care in an emergency room if you need that, right? So it's important to remember. So it's a great tool. It has to be used appropriately. But yeah, unfortunately, a lot of people who are uninsured or underinsured definitely benefit from that. And like I mentioned to you, we have patients stay on the study for sometimes up to 4 years, right? So that's incredible. Yeah. Yes. There's a piggybacking here going back and forth. You guys just kick me off the stage when you want me off. I don't know whoever's listening to this. Okay.
For the clinicaltrials.gov or other resources, do you know of many that are non-medicine? So I've been on some that are more so tracking stress and flares and things of that sort. So is that a good source for that, or are there others that you know of?
Yeah, so what a good resource for clinical trials. I think right now clinicaltrials.gov is a good one because it means to me if the investigator, and the question, just to be complete, was not just about medication, but other things, right? So we have a study on exercise in HS, right? That's not a pharma, yeah, that's sponsored by the HS Foundation. Thank you. So these studies, it's a kind of a quality assurance thing in a way. So if an investigator even knew that they have to put it on clinicaltrials.gov and kind of report to that, then that tells me they know what they're doing, and it's done in a kind of a safe environment for you. So I think it's a good way to be introduced to clinical trials. I would say definitely, and but not all studies are on clinicaltrials.gov. So but I don't know other resources that are so valuable. So to give you an example, they chase me down, and I was just told by my regulatory people I can go to prison if I don't report it in time. Yeah, right? So I have to report the outcomes, okay? I don't know how the other companies get away with not doing this, but apparently I'm the one who's going to go to prison. So we are required to report these outcomes. So it's very regulated. Everything you put there has been reviewed. And so I think it's a good way to have quality assurance. What was the question back there? Yes.
So when would you suggest a debriefing over a wide incision?
Great question. Okay. So the question is, when would you suggest de-roofing over a wide excision? So I'll give you a general answer, and then the rest of it is to be discussed, of course, based on your specific condition with your doctor. Because remember, there's 3 axes for the treatment. Okay? So any procedure you do, by and large, if it's not in the context of good medical care to control that inflammation, maybe not benefiting you, okay? There's a time, place, and exceptions for everything. Generally speaking, de-roofing is a procedure where you take one lesion, a tunnel or a persistent abscess, and remove the skin from the top of it, The advantage, it's easy to do, you heal faster, and it doesn't take away extra skin that's not needed, okay? That is usually suggested in these situations where the lesions are separated enough in the skin. So I think here on the North American guidelines, there's a good picture that I can show you. Yes. So here on the top, you see that there's a tunnel and maybe some bumps, some nodules around, but there is normal skin separating. So if you just had to take care of one tunnel, then that procedure is great. Sometimes you have many tunnels in the stage 3 or severe where they're interconnected, they're impacting the entire anatomical unit. Let's say the whole thing under the, oh, you're like 60% of the right buttock is all affected by that. Trying to deroof one doesn't make sense, and so then you need to do more bigger procedures. Sometimes, if you're medically controlled, right, so you've been 6 months on good treatment and really everything else is doing well, this tunnel system, even though it was really complex and wide, got so quieted down. There's so much less inflammation there that maybe a skilled dermatologist can actually do deroofing multiple ones in that area and maybe avoid the wide excision. But that's, again, case by case. So, yeah. And some patients want to just cut the whole thing out. And I say, we just do deroofing. It's like, doc, cut the whole thing out. I'm like, okay, I'll send you to the right doctor to do it. Okay? So some of it is also your choice. But these are the advantages of deroofing. It's smaller, it's likely to heal faster compared to that. Remember that with wide excision, it's not about cutting it. As my teachers told me, cutting is easy. It's all about closing, right? So to close a big area is much more challenging, right? So you will need, you may need like a big flap, right? Or if they do a graft, there's a donor site, and that's a pet peeve of mine because who gets HS, right? Young women, okay? They don't think it through, and that's the health literacy point, that you're now 18 and you just want to get rid of it, but when you're 22, you want to wear a bikini. And now, this whole thing is one big scar. Before that, under the armpit, you could hide it. Nobody knows. Here, it's a conversation piece. You wear a bikini, and that may impact you for the rest of your life. So we have to think it through, right? Yeah.
I've seen some doctors, they don't close the wide excision. So some people, or I guess it depends on the surgeon, that they leave it open?
Yeah, so the question is sometimes they don't close it. They leave it to heal, even on the wide excision, to heal what the professional term is by secondary intention, right? So they don't suture the skin and you walk out with a closed surgical wound. You leave it open to heal by itself. Yeah, it's a choice, and it can be done in the big, it's going to heal. It's just going to take time and a lot of wound care. I'm a big proponent of secondary intent healing. The hypothesis is, okay, it's not been proven, but it kind of makes sense, that if remember we talked about the microbiome, the bacteria in the skin. We talked there's too much of the bad ones. Those bad ones don't like oxygen. So if you heal open to the oxygen, then you will repopulate the skin, right? Within 24 hours, your skin gets colonized, right? So with bacteria. Then you will get the right bacteria, and they'll be strong enough to fight the bad ones if you heal secondarily. It's a hypothesis. It's based on some information, never been definitively proven for HS, but it makes sense. The other advantage you have is that HS typically is in skin folds, right? So the wound is not under tension. So it's going to heal very nicely, usually, right? So especially deroofing, because it's usually more or less aligned, it's going to heal almost like a surgical line. I have patients, I see them 3 years after deroofing, and I was like, did I close this with sutures? It looks so nice, right? Because if you have something on the back that's under tension all the time, the skin wants to open up, right? So you got to be careful. HS here in the middle of the chest, on the sternum, very, very difficult, right? Because the chest always pulls out, right? So HS on the scalp, you got to be careful with that. But under the armpit and the groin, the low tension areas, they tend to heal nicely. So secondary intent is definitely something to know. And that's education I give my patients, but that's, again, you empowering yourself to know. I'm going to send you to a plastic surgeon. I don't do these big procedures, but I want you to talk to them, because there's 3 options. They can move some skin, they can put skin from your thigh, or they can close it. They can't close it with suture, so they have to leave it by itself. So those 3 options, you got to know and understand the advantages, disadvantages. Okay. Yes, question from HR. Yeah.
Speaking of scarring, do you have any recommendations on how to help the scarring heal better?
I think so the question is, how can we have the scarring better? I assume scarring from surgery, not from the disease. But the answer is similar for both, actually. good medical therapy. So you want to prepare your skin for the procedure. That's why I usually don't recommend it in the first visit. So let's put you on a medication that will keep the inflammation under control, whatever it is that you need to do, maybe stop smoking, maybe lose some weight, kind of get your diet under control, see that you're kind of ready, mentally ready for this, spoke to your HR person that you need the weekend off, and then you can do that, and I think that will have the best outcomes also in terms of scarring. Interestingly, a lot of times what we see is not the hypertrophic scarring or the big scars, okay? What we see actually is what's called hypergranulation. The wound healed like almost too aggressively, so you get the wound bed kind of popping up, right? That's really the more common. Every now and then, if someone has a separate tendency to develop what are called keloids and all that, then we have to think about it. But generally speaking, I don't have significant problems with the scarring itself, okay?